We developed a three-tier system, and the idea is that the first tier would look at questionnaire formats to see how practice had changed and what surgeons had to stop doing and had to change. The second one would be looking objectively at the patients who had operations and procedures during that first peak for over a 12-week period. And then the third tier would be focusing on a 4-week period, looking at all of the referrals the vascular team received and what they did with those referrals and how that changed and was impacted compared to what they would have done before the pandemic.
And we anticipated that, things would be restructured. And that was what we found really with Tier 1, that there was a massive reduction overall globally in the services that were provided for a number of condition specifics as well. In the UK, that was most marked, and that was probably governed by some of the recommendations from the Vascular Society, which were very early and very appropriate. Some of the things we noticed really was that 65% of units stopped carotid surgery for anyone except very severe symptoms, which was a big change from perhaps pre-pandemic models. Intervention for aneurysms was reserved for those with symptomatic or very large aneurysms, and so those are quite big changes to the way that we deliver vascular services.
The key, I think, headline finding from Tier 2 is that the in-hospital mortality across the board for our key procedures was far higher for patients who underwent surgery during that peak time. We were looking at carotid interventions across the board at 11% in-hospital mortality compared to between 1% and 2% reported mortality pre-pandemic. At the same for our lower limb revascularizations, 9.8% in-hospital mortality recorded from our international cohort compared to reported in-hospital mortalities of between 1% to 5% for mixed presentation. And then the other thing we were talking about for Tier 3 is the sort of decision-making changes that, again, were forced upon ourselves and our colleagues. And between 15 and 20% of the patients that were referred across that 1-month period received a management plan that was different to the one that we would like to give them. So finally, what we did find that there was a very low rate of expected, suspected or confirmed COVID-19 rates amongst those vascular patients that had a procedure during the first wave. It was only 4%. But despite that, in patients who did have a positive or suspected test or had a diagnosis of a respiratory tract infection post-operatively, their mortality, their risk of in-hospital mortality was almost 5-fold.
The messages were broadly the same, the mortality and the reductions in services. But obviously we have a designated national screening program, and that was one of the bigger hits that the vascular service took, a reduction in the availability of screening. Post-operative EVAR surveillance was reduced considerably, and interesting parallels were drawn across most of the world. We worked very closely with a team in Australia who found quite different outcomes for some of the outcomes, including mortality, and that may reflect some of the severity of the pandemic there compared to what we experienced here and in Europe. But broadly speaking, across the United States and Europe and over into the Far East, we noticed that things were very, very similar. Some of the specific things for the UK were that we found that there was a shift towards, certainly reported shift in the survey with regards to endovascular management for lower limb critical limb threatening ischemia. So that's quite unique and quite interesting for the UK data and going forward. And it'd be interesting to see how that pans out over the next 6 to 12 months with our follow-up data and the ramifications.
Looking at the recovery in the period after the first hit, there are a lot of centres, about 20% of our centres still have more than 20 aortic cases lining up still to be done. And that will keep building, and that will keep building as more aneurysms are screened and identified. It will be a time where we will see increasing competition for services, and it will be on us to be advocates for our patients. So I think that's the main change, is that our strength of advocacy will have to increase over the coming months and years. It will return to normal eventually. I suspect some of our management protocols might change a little from the experiences that we've had during the COVID pandemic, where we've stepped back on services and our patients haven't been impacted by that change. And that might give us the space and the bandwidth to recover more quickly than we might have done otherwise. I'd like to think that the key message has been the power of the collaborative research model that we've been able to run. We are not the first, but in terms of trainee-led research, the engagement that we've had internationally, and hopefully the outputs that we've been able to provide for that, have been powerful. And I hope that this can continue with research in the future, especially when it's something with a true international impact like COVID-19.